Hello friends, myself Dr. 𝐪𝐿𝐴 𝐽𝐿. Today I have selected a topic to take up the image-based questions which is important for NEET PG 2021 and also it is important for FMG exam. So today I am discussing the part 1 of this, and in my subsequent videos I will be discussing more image-based questions. So I start with first question. A 35-year-old female presents with an adnexal mass. CA-125 is slightly raised. CA-19-9 is normal and LDH is elevated. Tumor was resected and gross and microscopic image were given as below. So you see, this is a 35-year-old female and there was an adnexal mass, and this mass was operated. On gross examination is this image, and this is the microscopic examination. This is one of the AIIMS PG question which I am discussing. In this, one thing I would like to tell you that in 𝐽𝐵 question, most of the time there is a clinical history being given and there is always a hint in the questions where you have to grasp the hint to mark the answers. In this question it is written CA-125 is slightly raised. Slightly raised. That means it is not a malignant ovarian tumor where CA-125 is markedly raised, which is malignant epithelial ovarian tumor, and that is usually occurring in the menopausal or postmenopausal age group. So this is a reproductive year age female. But here it is written that LDH is elevated. Okay. So there are 4 options given, that it is papillary serous cyst adenocarcinoma, or it is teratoma, or it is dysgerminoma, or it is choriocarcinoma. Fine. So LDH is elevated and CA-125 is slightly elevated in this case. Okay. So papillary serous cyst adenocarcinoma we can rule out because CA-125 is not markedly raised, and number 2, this is not the not goes in favor of epithelial ovarian tumor. Number 2, teratoma, and mostly teratoma is dermoid cyst and it does not produce any tumor marker. Choriocarcinoma to arise as a germ cell tumor, although rare, and tumor marker for choriocarcinoma is beta HCG, which is not the case. Dysgerminoma is the correct answer, and tumor marker for dysgerminoma is LDH and alkaline phosphatase. Okay, so the answer for this question is alkaline phosphatase. So dysgerminoma. Dysgerminoma is a germ cell tumor of the ovary, and usually it is occurring in young age group most of the time. Dysgerminoma is most common pure malignant germ cell tumor of the ovary. Mind it, pure malignant. Then tumor marker it secretes is LDH and alkaline phosphatase, where LDH is given as the hint, and this tumor is radio sensitive. This tumor is radio sensitive. Now, since in this case it is 35-year-old female, although this tumor is usually occurring in the adolescent age group, that is less than 20 years. So the treatment in this case we are going to give will be unilateral oophorectomy, where they have already said that tumor has been resected. And if there is a need, then biopsy can be taken from the opposite ovary, and if there is any chance of metastasis, then chemotherapy in the form of BEP can be given. BEP, bleomycin, etoposide, and cisplatin. Now friends, when it is a radiosensitive ovarian tumor, why we are not giving radiotherapy? Because the side effect of radiotherapy is it causes vaginal stenosis, it causes bone marrow suppression, it can cause ovarian destruction. Since the female is in the reproductive age group, so we have a limitation, we cannot give the radiotherapy. Next question. A patient presenting with an adnexal mass was operated and the following tumor was removed. What is the likely diagnosis for this case? If you see carefully, in this tumor, again it is written an adnexal mass. This is again a question from AIMS PG. And always there is a hint in the question. If you see the image, you can see there are hair, teeth, bone, sebaceous material, etc. So this goes in favor of dermoid cyst. Let's just look at the options. Is it mature teratoma? Is it dysgerminoma? Is it granulosa cell tumor? Or it is mucinous adenocarcinoma? Well, from the image, it looks as the image of dermoid cyst. Okay, so we should mark the answer as mature teratoma. Few points about dermoid cyst. Dermoid cyst is most common germ cell tumor of the ovary. It accounts for 95% of all germ cell tumors. On cut section, it contains hair, bone, teeth, sebaceous material, etc. That means it is ectodermal in origin. Now, only 10 to 15% cases, dermoid cyst is bilateral. So mostly it is a unilateral tumor. Now, the risk of malignant transformation of dermoid is just 1%. So it is usually rare. Risk of malignant transformation of dermoid is just 1%. So this is rare. Next, this is most common ovarian tumor which undergoes torsion or twisting. This is most common germ cell tumor of the ovary. This is most common ovarian tumor which is associated with pregnancy. Fine. So treatment for dermoid cyst is ovarian cystectomy. Ovarian cystectomy. Now let's move on to the other part. Next question is identify the type of contraception. This is from this image today. Okay, diaphragm has got a separate type of image. Fem shield is a female condom and another option given is the male condom. So today is a vaginal sponge which releases a spermicidal agent nenoxynol 9, and the failure rate is 9 to 30 per 100 women year. So there was a recently asked question in FMG exam, what spermicidal agent today releases? So answer, it releases a nenoxynol 9. Next, this type of IUCD is freely available in India. What is this IUCD? Is it Mirena? Is it copper T380A? Is it copper T200? Or is it progestastat? Well, this is an IUCD where the vertical stem contains copper, horizontal arms contain copper. So the freely used IUCD in India is copper T380A, which is a government supply IUCD, and it is also the longest acting IUCD, where effective period is 10 years, and failure rate of this IUCD is 0.6 per 100 women year. Next, identify the type of IUCD and what is the failure rate of this IUCD. This IUCD, which is shown in the image, is Mirena. Okay, there are 4 types of IUCDs. Number 1 is biologically inert IUCD, which is Lippy's loop, where that is just a plain IUCD and it was just implanted in the uterus, and the mechanism of action is prevents implantation. Whereas that is already been not available because of so much of the side effects. The next second type is the copper releasing IUCD. Here in this case, you don't see any copper. Number 3 is the hormone releasing IUCD, and nowadays the most widely used IUCD, hormone releasing, because it has an advantage as it can be applied in the menstrual disturbance patient, it can be applied in the patients with dysfunctional uterine bleeding, etc., with the patients of the PMS, that is pre-menstrual syndrome patients, or endometriosis patient, where there are many advantages. So Mirena is a hormone releasing IUCD, and effective period is 5 years. Failure rate is 0.1, and it contains 52 milligram of levonorgestrel and releases 20 micrograms per day. Advantage of Mirena is it reduces the menstrual blood loss to near about 97%. So it is very useful in menstrual disturbance patients, like dysfunctional uterine bleeding. It is also useful in the patients of premenstrual syndrome, in endometriosis. So in modern times, it is just an alternative to hysterectomy in many of the cases. Next, identify the sterilization method. Well, this sterilization method, you can see there's a Babcock's instrument which is being used. That can be an instrument-based question. So in my next video, I will be taking up the video where I will be talking about the instruments. Okay. So this is Babcock's forceps, which is used to hold the tubular structures like fallopian tube. A loop is being made and there is a ligature which is being tied. Okay, most likely this is the isthmic part of the fallopian tube which is being tied. So it is Pomeroy's technique. Okay, in the modified Pomeroy's technique, the fallopian tube is being cut and sent for the histopathological examination. Okay, so the most practiced tubectomy method in India is the Pomeroy's technique, and the suture material used is the catgut. Next. A young girl presented with primary amenorrhea at 14 years of age with no breast development, and what is the diagnosis from the image? Young girl, 14 years of age, presented with primary amenorrhea and no breast development. From this image, is it look like Down syndrome? Not really. Is it Turner syndrome? Let's just look. Klinefelter syndrome occurs in boys. Androgen insensitivity syndrome, it does not present like this. So this is Turner syndrome. From the image we can see this was one of the question which was asked in NEET PG exam. Okay, there was an image based question. As far as I remember, a similar question was asked in 2014 exam. Okay, so in this case, the girl has presented with primary amenorrhea. There is no breast development, is 0. And can you see there is cubitus valgus deformity. There is congenital webbing of neck. So this is a clear-cut case of Turner syndrome. Another name for Turner syndrome is ovarian dysgenesis, and the karyotype is 45XO. So from the physical appearance, congenital webbing of neck, no breast development, primary amenorrhea, cubitus valgus deformity, it goes in favor of Turner syndrome. In my subsequent videos, I will be talking about disorders of menstruation, where I will be talking about details of the Turner syndrome. So this is, and just remember, the most common cause of primary amenorrhea is Turner syndrome, and the second most common cause for primary amenorrhea is Mullerian agenesis. Next. 25-year-old female presented with infertility. Semen analysis is normal, ovulation studies are normal, and HSG shows this. Hysterosalpingography shows this. Now, semen analysis normal, that's a young infertility patient. Ovulation studies are normal, and HSG shows this. Hysterosalpingography. Does it look like PCOD, or it is ectopic pregnancy, or it is Asherman syndrome, or it is septate uterus? First of all, this is an image of the uterus. Okay, so PCOS is already ruled out. PCOS, that is polycystic ovarian disease, occurs in the ovary. Number 2, ectopic pregnancy. Again, why should we be doing HSG in ectopic pregnancy? Number 3, Asherman syndrome or septate uterus. Well, you see clearly the HSG image showing irregular filling defects. Irregular filling defects. So this is usually the Asherman syndrome. Okay, septate uterus again does not look like this. Fine. So Asherman syndrome is usually a cause of secondary amenorrhea, which develops after you have done a vigorous curettage during MTP, or like during DNC, or post-cesarean or post-delivery. Okay, so the maximum chance for developing Asherman syndrome is postpartum curettage. Then clinical features. Clinical features of Asherman syndrome includes oligomenorrhea, hypomenorrhea, secondary amenorrhea, or infertility. The most common presentation of Asherman syndrome is hypomenorrhea, which was asked in one of the AIMS PG question. Investigation done is HSG, which shows irregular filling defects, and the gold standard investigation is hysteroscopy. Hysteroscopy, which is diagnostic as well as therapeutic. So hysteroscopy remains the diagnostic as well as therapeutic. Now, this test is done in a woman being investigated for infertility
which of the following statements is true? Okay, so a female was investigated for infertility, and this is an HSG image which is showing. Does it show submucosal leiomyoma, or it shows normal tube patency HSG, or HSG shows irregular uterine cavity and beaded appearance of the fallopian tube, which is suggesting, or it is showing hydrosalpinx. Clearly, if you see, there is distortion of the uterine cavity and the fallopian tube looks beaded in appearance. So this is clear-cut a case of genital tuberculosis where there is irregular uterine cavity and beaded appearance of fallopian tubes in this case. So this is a genital tuberculosis. Next. A 30-year-old patient presented with infertility, HSA is normal, that is semen analysis. Ovulation study is normal, and hysterosalpingography shows image like this. So is it bilateral distal tubal block, or it is Mullerian anomaly, or it is Asherman syndrome, or it is PCOS? So this image, there is no free spill which is being seen, and the distal end of the fallopian tube looks blocked. So this is bilateral distal tubal block, which is presenting with infertility. Next, a young unmarried girl presents with secondary amenorrhea, and ultrasound done shows this image. A similar question was asked in NEET PG 2014. So is it fibroid uterus? Is it PCOD? Is it dermoid cyst? So it is a clear-cut case of polycystic ovarian disease. Soon I will be releasing one video on the polycystic ovarian disease where the treatment options, where there are presentations, where there is a Rotterdam criteria, I will be discussing in that. Now, this is a 30-year-old primigravida came to the OPD with complaints of bleeding per vaginum associated with pain. On examination, abdomen is soft and non-tender. Palpation, the uterus is enlarged 12-week size, soft, non-tender, and no cervical excitation. No cervical excitation, non-tender, so it does not go in favor of ectopic pregnancy. Ultrasound image is given below. Okay, so in this case, there is bleeding and the uterus is enlarged to 12 weeks size. Okay, if you see clearly, it looks like snowstorm appearance. So this image, if you see, it is a clear-cut image of H. molar pregnancy. Blighted ovum does not look like this. Ectopic pregnancy, because in the history there is no cervical excitation, and again it does not go in favor of missed abortion because the ultrasound image clearly shows snowstorm appearance. So it is again an image of the AIMS PG question, like, and which is important for the NEET PG exam also. Now, 35-year-old female came with para 2 L2 and one abortion, came with a history of hemoptysis, dyspnea. She had history of H. molar evacuation 4 months ago. And now the chest x-ray shows this, and beta HCG is elevated. Chest x-ray, beta HCG elevated, preceding history of molar evacuation. This clearly shows cannonball appearance. So this is clearly a case of choriocarcinoma. Details of choriocarcinoma topic, I will be taking up a separate video. Now, identify this instrument which is used for fractional curettage, endometrial curettage, endometrial biopsy, installation of hysterosalpingography. Well, this is a disposable Karman's cannula, and this is used for endometrial curettage when we want to take up a case for EA plus ECC. EA is endometrial aspiration cytology, And an ECC is endocervical curettage, which is an investigation which has been done when a female is presenting with postmenopausal bleeding. So this is used for endometrial curettage. So the part 2 of the video I will be releasing soon with more image-based questions. Thank you.